right, Dr. Javadan, I'll invite you up to the stage for some case presentations, and then we will break for lunch around probably 11:50 or so.
All right, great. And again, thank you, Kylie and Lionel, for the invitation for the course. So we'll start with a pediatric case. And I was told by one of my colleagues to pick on some of the residents that are visiting us this morning. So thank you. So you can thank him later. But this is a pediatric case. It's an 8-year-old female that was followed by a colleague at the Shriners Hospital. So 8-year-old female, and I think it's Connor here from Zale? No? All right, how about one of the other residents? What do you guys see on this x-ray?
First, most notably, I see some pretty significant kyphosis in the upper thoracic spine. And maybe definitely looking at the sagittal balance, the occiput is anterior compared to the sacrum.
Okay, perfect. So yeah, good observation. So there's like a sharp kyphosis in the upper thoracic spine and then some hyperlordosis compensating for that in the upper cervical spine. And you know, this gets you worried about a deformity up there, but obviously at the shoulder level, it's very hard to see. So are you going to order further imaging for something like this in a child?
So I'd probably want to get an MRI. I'd also like to see an AP, the coronal balance.
Yeah, perfect. So you want further imaging, and MRI is great. It doesn't have radiation. We did have an MRI. This patient was diagnosed at the age of 2 and was conservatively followed. She was not very symptomatic, but looking at that, she had a congenital vertebra with failure to formation in the anterior column, so congenital kyphosis. And maybe one of the other residents can comment. Are there any other considerations at this early age when you diagnose this for this patient? Are there other studies or consultation that you might want to get?
Pass it along. Keep going.
Pass it along, or if you want to answer, go ahead.
I mean, I would think other sort of congenital abnormalities as well, heart, kidneys,
perfect,
brain, other intraspinal stuff.
Great. Your residents are very smart, Matt. So exactly, so you want to send them for a cardiac echo, renal ultrasound. So perfect answer. So the patient was fully evaluated. She did have a little bit of a low ejection fracture, but a structurally normal heart and a mild physiologic pulmonary valve regurg. However, when she presented to me at the age of 8, she was having some on and off back pain, but she had started to develop some progressive radiating pain down both legs. As you can see on the MRI, the cord is rather draped over the congenital kyphosis, and later on for surgical planning, we do get CT scans, and I use models quite often for cases like this. So, and I feel like a model is a much better, a 3D model in my hands sitting on my desk is a much better tool than anything that I could see on a 2-dimensional screen to plan these patients. So here's a video of the kyphosis. As you can see, there's a failure of formation of the anterior column at 2 levels, but posteriorly, the posterior elements are well preserved at those levels. So we use this, and these models can also be sterilized if you need them and brought into the OR because they are a very good tool for us to locate the anatomy and plan the surgery. Obviously, the use of navigation does help you do that if you have that technology available and is part of your workflow. So if anyone else, any of the fellows want to come up with a plan potentially how they would want to tackle this case and what are some of the considerations?
Case, I would probably lean towards obviously shortening the spine and resecting that wedge vertebrae, and possibly it looked like there were some malformed vertebrae 2 levels above the posterior elements of those 2 levels above. So I think it's probably T3 and T2 resection with a costotransversectomy.
What do you think? I mean, that's pretty morbid, though, right? For the cord, what do you think of a laminectomy procedure and just in situ fixation of something like that?
It's an option, but I don't think the cord is going to drift back over those anterior elements.
Yeah, and I think that is a worry, and unfortunately, sometimes we see procedures like that being done. I think in a case like this, a posterior procedure won't effectively get the draping of the cord and address the, this is a developing myelopathy. It's rather mild at this point, but it could become more severe, and the cord can become more sick, obviously. What about a anterior resection rather than doing this posteriorly? Would anyone consider taking this out anteriorly? So it is a thought, but again, in these kyphotic deformities, it's much easier actually going posterior because the anatomy is actually posterior, and doing costotransversectomy type of approach is rather easier. And if you go anterior, you're working in a very deep field trying to reach for that far vertebra. So our plan was positioning in a rigid position, or usually put it in a Mayfield, and the resection of the vertebral column T3 and T4. And I usually put a small cage of some sort to be able to maintain some of the column height, but also to hinge from. But I think one of the most important things that I learned from my mentors was that a sick cord really likes to be shortened. They definitely don't tolerate any lengthening. So taking a lot of posterior bone and being able to shorten the column posteriorly is very important for the health of the cord. So I've moved to doing my laminectomies with an ultrasonic bone scalpel, which is a good option, decreases blood loss, and once you get used to it, it's a very fast procedure. So we did a laminectomy as those 2 levels after instrumenting up and down, and performed a vertebral column resection and placed the anterior cage. So I usually, once I am completing the VCR, I usually put a rod to protect the loose spine at that point, and we use a compression technique to shorten the column. And on the picture on the right, you could see sometimes when I don't have a lot of fixation, especially in small kids, I do use a sublaminar band or something to augment the screw construct as well. Yes.
Maybe just a couple questions and discussion points. How did you manage roots for the 2 levels? Did both 3 and 4 have their own roots, and did you take them on both sides or just one side? Or?
Yeah, that's a great question. I think I've been trying to take the roots a little bit less. I think early on, I was pretty cavalier about taking the roots. But at that level, especially at 4, I'm not very worried. And I usually will take at least a single root on this side where I'm mostly working. I do let so sometimes we take it bilaterally, especially when the fellows are further along and they do a good portion of the VCR from their side and then I do my side. But I'm usually doing most of it from my side, so I do take the root at one level.
Yeah, and I think Dr. Galvin brings up a great point. At T3 and T4, you're not thinking about eloquent roots, but if someone has a post-fixed brachial plexus, T2 can innervate the hand, so you need to be really careful when you get to the upper thoracic spine.
Thank you. Great point. So you could see on the fluoro shots, that's a small mesh cage that we place anteriorly, again, to hinge and shorten the cord. We did have a neuromonitoring alert, so I'll pick on my own fellow then and Brandon, who's going to be in practice in a couple of weeks. So when neuromonitoring alerts happen, what is your thought process? What is what goes through your mind, and how do you deal with a neuromonitoring alert? So we had loss of motors in the right lower extremity, and this is actually during the decompression. So we haven't even done any VCR or any work anteriorly, so kind of early in the game.
Yeah. This is obviously well documented in literature, and we have checklists in the Shrine Hospital as well, where everyone kind of takes a pause, and you have some of the stuff already listed, but increasing your MAP goals, giving some decadron, decreasing the anesthetic, and then if you're at the deformity aspect of the case, you'll undo your correction, and then continue running motors, and just having constant communication with both your anesthesia staff, your circulator, and the neuromonitoring tech to basically undo and try to mitigate all the things that you can control, like we just talked about, and then trying to troubleshoot some of the other stuff, like making sure that their equipment is working properly, there's no leads that came off during the case. And some of the times we've had some cases where maybe the patient's like leg or something got started falling off the table, wasn't positioned correctly, and so they look under the drapes, they're able to adjust whatever needs to be adjusted, and usually those things can be resolved.
Great answer. So I think the most important thing is to have a plan and to have some sort of protocol, to talk to the team at your pre-op huddle that you're doing a high-risk case for neuromonitoring alerts and that you have a plan. Having a plan and laminating it and putting it into the OR is also a very good idea. I think it even starts in the pre-op area. So I always meet with a patient and I tell them, hey, if you hear us tell you move your ankles or move your legs, this is what I want you to do. And I practice that with them. Just getting them mentally ready for that gets them ready for a wake-up test. So don't forget about the wake-up test, something that I think we don't do very often. I remember my first year in practice, I had a neuromonitoring alert. I got quite nervous. We couldn't get it back. I got out. It was over Christmas break, and I called my father, who's a spine surgeon. I said, hey, what do I do? He said, do a wake-up test. We did it all the time before neuromonitoring. And, and you ask the anesthesiologist to do a wake-up test, and this is one of my favorite things to do now. As soon as I lose it, I tell the anesthesiologist, we're going to do a wake-up test. And they're like, what? And they turn down the anesthetic, and 95% of the time, everything comes back. So decreasing the anesthetic, getting hemoglobin on the patient, making sure the maps are at a good level, and a little bit of waiting. some people like using warm IV saline just to vasodilate, and then also checking, making sure the screws you place or a cage you place or a piece of bone is not on the cord. And then if that doesn't work, you have to kind of undo the last move that you've done. So for example, if you close the osteotomy, maybe release it a little bit. And we'll talk a little bit more on the scoliosis technique when that happens in scoliosis surgery, moving to softer rods and things like that are always a technique. So have a plan, talk to your team, don't get nervous, and again, be very open with it, talk to the anesthesiologist. Those are very important things to keep the room calm.
I'll just add, I think those are priceless pearls for managing neuromonitoring loss. I think the other keys are having frequent enough monitoring, motor evoked potentials that you can backtrack when, what maneuver caused the issue. If you're only, running every half hour and you're doing a lot of these maneuvers with your VCR, you're going to have no clue what caused the motor loss.
Yeah, absolutely. Great point, and thank you for reminding me of that point. So part of our protocol is also the standard protocol for neuromonitoring is usually running motors every half an hour. So in scoliosis, in the reduction maneuvers or in VCRs, when we start doing the VCR, our protocol is that we go to 5 minutes to 3 minute interval motors. So when I'm actually performing a VCR, the neuromonitoring is always alerted that they're going to run motors every 3 minutes. And then for another 15 to 30 minutes after the osteotomy is closed, they're running them at 3 to 5 minute intervals, because exactly as Dr. Metz pointed out, you want to have very granular data when you lost those motors. And it doesn't help if they say, well, it was somewhere in the last 45 minutes or an hour. And you're like, well, that was the start of the surgery. And that would be very unfortunate. So this is her. We decided to put her in a cervical thoracic orthosis just to protect that short fusion just for about 8 weeks. This is 1 month post-op and 6 months. She was doing quite well, and the sensory changes in the lower extremities did get better.
Awesome. Any questions about this case? I think we have one more before lunch. Time for one more.
Okay. So I'll jump into the next one. Kind of a similar pathology. Sorry, was there a question?
Was there someone behind? Okay, sorry. Just one question, probably mainly for my residents, and you brought it up. I had a similar experience in fellowship with Ro doing a similar case. But when you're doing a VCR and the cord is compressed, a lot of times you'll get the monitoring change while you're doing the release, and so putting that rod in early, not waiting till later, that'll help you maybe avoid some of those situations. Because I think classically, in your training, you kind of think of like, oh, during the deformity correction, that's when we're going to get the neuromonitoring change. But in these type of cases, it's actually when you're starting to release some of the things that are holding the rigid deformity fixed, the cord can start to stretch a little bit or drape a little bit more over that deformity. So having that stabilization in there early is good.
Yeah, absolutely. That's a great point. Always stabilize an osteotomy before you completely release it. And a good tip is also put a soft, small diameter rod. So like I usually use a 5.5 titanium rod, and that allows you to inside to bend in any direction that you want to manipulate that. And if you it'd be very difficult for you to do that. So use a short, flexible rod to do that. So this is a patient of mine who was treated as a pediatric patient. He has NF type 1, and he was treated at an outside facility. He obviously had quite of a deformity after his index surgery, which was at the age of 17. But unfortunately, he had 3 revisions after that, where some hardware was revised, and he did have an episode where he had an infection post-op, and that was treated. And he was diagnosed with osteoporosis, and he was on Prolia by his endocrinologist. But when he came to our clinic, he had about a year where he was getting weaker, and by the time he showed up to our clinic, he was using bilateral crutches to ambulate. So legs were quite weak, but he was still walking. The chief complaint that he had was that he had lots of difficulty holding his head upright, and he had a lot of neck pain by noon and afternoon. And obviously the progressive weakness in the bilateral extremities. Do any of the residents want to tackle this, or maybe more of a fellow case, or even any of the young attendings want to give their thoughts on what's going on here?
Raph, are you back up? Are you the only fellow in here? Fellows get hungry apparently before other people, so they're all out there.
Okay, I'm sorry, I missed so what were his complaints?
The biggest thing was paretic in the legs, so getting weak in the legs, and severe neck pain.
Zach's actually going to take this.
All right.
Thank you for the opportunity. Sounds fun. So you said that he's having neurologic changes.
Yes.
And he has a significant deformity that's limiting his activities of daily living and his ability to be comfortable. It seems like he has a complex sagittal plane deformity and a coronal plane deformity that's overall more or less balanced. I think to approach this case, I would break it down into what needs to be decompressed to get rid of his neurologic symptoms, and how to best address his deformity in both planes to have a stable functional alignment for this young gentleman who also has with this complex problem. Taking into account his global alignment here, it looks like he has significant problems from the lumbar spine all the way up. That being said, I think I would ignore that and focus locally at his at the proximal end of his construct, and that really, I'm going to call it PJK caused by this osteoporosis and above his previous fusion construct. I think I would do some type of 3-column osteotomy. I need to see three-dimensional.
And I'll show you more. I mean, obviously you're very well trained because you kind of dissected that case very well just with the limiting imaging that you have. Exactly all the considerations that we thought is what kind of decompression this patient might need, how to address some of the deformity. And you pointed out really well that this patient also has an iatrogenic flat back type deformity. So does that get addressed in the same surgery later, or does it ever have to get addressed, right? So those are all very, very important questions. And as you could see from this one sagittal MRI image, there's a rather complex anterior kyphotic deformity with bone spurs that the cord is draped over. So very, very sick cord and rather dangerous dissection over that kyphotic deformity. So again, to better look at the deformity, we do get 3D recons with the models made, and you could appreciate there is a pseudarthrosis at the thoracolumbar junction with a rod fracture. Our thought process was we definitely have to address that. So that was at least the least distal level that we had to go to. So we had to go there and address that. But we were going to obviously focus on the kyphotic deformity and the decompression. And to make this case a little bit harder, patients with NF have a lot of dural ectasia, so their dura and bone is not normal anatomy and makes it rather difficult. So this is an MRI of the thoracic spine. And again, you can see the dural ectasia, and you could appreciate the draping of the cord. This is the lumbar. You can see very small lumbar pedicles, obviously, with a large dural ectasia. So the patient's problems, as you pointed out, rigid cervical thoracic deformity, kyphosis with the cord draped to the anterior bone. There is a pseudoarthrosis we have to take care of, iatrogenic lumbar flat back, and then we have to get good fixation and somehow deal with that sick thoracic cord. So I guess I would poll the audience and maybe ask some of our senior colleagues, would they consider doing the VCR and correction, and also doing some sort of lumbar osteotomy to correct the no lumbar lordosis. The lumbar lordosis is almost zero. So taking care of the iatrogenic flat back at the same surgery, or maybe staged in the same hospitalization, like 1 week apart, or would they do it completely remotely?
I'll take a quick stab. Or, well, Sig, why don't you chime in?
Yeah, no question. In line with this is a staged operation. This is really a high-risk problem. The understanding myelopathic, kyphosis that these.
Yes, severely myelopathic at this point.
Yeah, this is one to take care of myelopathy and focus on one segment. I think even in same-day surgeries, thinking about segments separately, it's easy to fix one segment at a time. Trying to get a single rod from T3 to S1 becomes really challenging. So fix that 6-7 area, and then, depending on how things are going, you may consider carrying on. But you would do that as a single stage, not 5 stages over possibly 2 admissions.
Great.
I agree with Stig. I think you definitely, high risk case, you don't want to exhaust yourself and try to do too much. I would do the PJK, the osteotomy there, probably fix the pseudo, and then I would favor a second admission, just let him heal and not reopen a compromised soft tissue bed.
Yeah, great. And thank you, Sig. That's a lot of experience talking right there, and that's very, very important. And that was after reviewing this case with some colleagues, that was our plan as well, to address the myelopathy, address the thoracic kyphosis, and go below the pseudoarthrosis level, but link into those rods and just use that as anchors for the initial surgery. So this is the patient position. I use a table that has a bend in the middle, the pro-axis table, so you can place the patient in a kyphotic position, and I use this a lot more for my PSOs and osteotomies in the lumbar region, but it becomes very helpful to put a patient in a relaxed position and then manipulate the position as you release the spine. So as you can see over here, this is after dissection. That's the very rigid, well-fused kyphus over the upper thoracic spine. After their placement of some instrumentation proximally, which I'll show you later, we did a decompression. In this case, we did sacrifice 2 levels of nerve roots. In NF deformity, that is a classic penciling of the rib, kind of inserting into the canal. So we did remove the rib heads at those level, and they were quite intimate with the dural ectasia on the lateral sides. We had a couple of great talks about navigation. This was one case that I was glad that I do have a workflow and access to navigation and some experience with it. I don't normally use it but this was a perfect case to use navigation for. As you could see, I was able to look at where the junction of the deformity was and also used it for proximal screw fixation, because those pedicles were at best maybe 3 or 4 millimeters in the upper thoracic spine. At this point, we sacrificed the nerve roots and planned our resection of the bone. And you could appreciate on this image where this is the dura, and this is the dural ectasia. It almost doubles the diameter of where it would be. And after studying the model, I thought it would be much easier to do the VCR from the right side. However, after exposure, I soon learned that trying to navigate this dural ectasia was going to be very difficult. So we actually ended up doing the 2-level VCR from the left side where I was standing, essentially working right under the cord and completely reaching over and resecting the vertebral bodies at that level. And as we mentioned, Dr. Metz mentioned regarding putting a rod to control the osteotomy, used a small diameter titanium rod to control it initially, placed a small cage, anteriorly mesh cage, to be able to close the osteotomy, and then we were able to close the osteotomy over that. And those are the post-op x-rays. I was actually surprised that we were able to correct the coronal alignment better than I thought as well, both coronal and sagittally. You could see the small mesh cage, and that's kind of our correction in 3 dimensions compared to where he was before. Clinically, he's doing quite well and slowly improving cord function and strength and walking at this point. He's about a month post-op, and my plan is to go back in about 5 months, reevaluate how he has healed, and see whether if he wants to pursue a correction of the lumbar portion. And this might be a good discussion point as well with our adult colleagues. Initially, my plan was to perform a pedicle subtraction osteotomy, usually at the L4 level. But after reviewing the model and his bone, my plan currently is to go do cut the rods at the probably like L3 level, do a posterior release, remove the instrumentation, do a hyperlordotic ALIF, and go back in the back and fix them with pelvic fixation. And I think that would get them enough and avoid me having to dissect around that dura, which is probably 8 to 9 centimeters in diameter because of the dural ectasia and very scant bone. So I would appreciate thoughts on people that have a lot of experience doing that. If the front back with a hyperlordotic ALIF would be better than a pedicle subtraction osteotomy.
Yeah, I like the idea. First of all, you did a beautiful job on that first part. But I'd try to stay out of the dural ectasia. And, I've done a lot of ALIFs in my career and some front backs. It's, time consuming, but you're going to get more harmonious correction and less likely to get into the nerve roots and that mess. So I think it's a good idea. I'm not sure if you'll get it all at one level, though. You may need 2. If you can do posterior release at 2 levels and do 2-level ALIF, I would look at the math and see what you need in terms of how much correction you can get.
I agree. I would do a front back. The question, I think, is where to do your ALIF. You said 3-4. Why 3-4 over 4-5 or 5-1, I guess?
No, sorry for the misunderstanding. I was going to do a 5-1 ALIF.
5-1 ALIF, okay.
I was going to cut the rods around L3 and then posterior release 3/4, 4/5, 5/1, and then
Gotcha.
maybe do one. And if I could get a second ALIF, it'd be nice, but probably a hyperlordotic ALIF at 5/1. And then if we had vascular access at 4/5, then that would be great as well.
Yeah.
I think the other thing is he complaining of back pain? I know you said the pre-op he had myelopathy and neck pain because of the hyperlordosis from compensation, and he looks much better now. Even pre-op, like he's balanced because of the compensation. So if he's not complaining, maybe you could just watch him. Leave him alone. For now.
Exactly. That was kind of our plan, to reevaluate in 6 months and see how he's doing. But I wasn't going to do it any sooner.
Yeah, it's very interesting. If you look at his initial standing lateral, his pelvic tilt is probably in the 60s or something like that. It's just incredible what young adults can do. But I think predictably, as he gets older into his 50s and so on, he's not going to be able to compensate that way.
Right.
So I think I agree with Lee. I don't think it's urgent, but I think at some point he'll be doing the reconstruction.
Yeah, that's a really good observation. Obviously we didn't do anything in the lumbar spine, but the compensation with the pelvic tilt, you can see improved. It's not anywhere close to normal, but significantly improved from where it was just by correcting in the upper thoracic spine, which is very interesting, even with a rigid lumbar spine.
And also, just one more point, maybe you can tell us a little bit more detail. With thoracic VCRs or PSOs, people do it differently using osteotome, a burr, or curettes. With these, with anterior compression of the cord and the anterior spinal artery being under compressed, and so on and so forth, you really want to minimize the amount of sort of disturbance of the cord. What's your preferred method for something like this to remove the vertebral body? Is it burr, is it curette, or osteotome carefully? What's the safest way?
Yeah, great question. I kind of use all those tools interchangeably for different pathology. For example, for a rigid PSO in the lumbar spine, I've been using the ultrasonic bone scalpel for my initial cuts, and a lot of time I use 90-degree osteotomes to complete it. For this, I just used a lot of curettes, large curettes, to just curette out the bone slowly and just work away from the cord, not a lot of high-speed burrs or instruments like that. So mostly curettes.
I think it's important to know many ways to do everything, but I think this is in particular important to use low percussion instruments. The only other pearl I would just point out for the fellows and for the residents is you have to, Dr. Javanan did this excellently, but you have to be able to follow the continuity of bony fusion from top to bottom. You see a lot of people who do VCRs and they'll leave intercalary discs or something where you're not getting, your fusion's going in the posterior elements, but then once you get to the osteotomy, it's going through the anterior column. So you have to be able to really follow, that continuity of bony fusion from top to bottom, or else eventually your rods will break. Nice case.
Thank you.